So I think we'll just go ahead and start. There's a lot of stuff to cover in bronchoscopy, but I'm going to skip over some of the unnecessary details. So at the end of the day, if you can remember maybe, I don't know, 50% of it, I think you'll be fine. It's that dense. Dr. Delap. All right, so bronchoscopy. So this is the general outline of our talk. We'll talk about a little brief history of bronchoscopy. This is actually a very interesting topic for me because the history of bronchoscopy is incredible. Then we'll talk about the tracheobronchial tree, some points about sedation and anesthesia, then diagnostic bronchoscopy, and this is where we'll spend most of our time. The therapeutic bronchoscopy is really like an IP talk. I'll introduce this idea of functional bronchoscopy. This is a term and some concepts that are still out there and being tested, and then a few things about how we train and check for bronchoscopy competencies. So you probably have seen this picture before. Juan, can you turn the lights down a little bit, please? Thank you. So this is Dr. Gustav Killian from Austria, who was actually an ENT surgeon, and he's the first one who performed bronchoscopy in the complete sense of the word. There are a lot of people who tried before that. Bronchoscopy was always important, or people thought about it, because for decades and centuries, diphtheria, tuberculosis, and foreign body aspiration were universally fatal. So anyone who had any kind of medical inclination was thinking about how to approach the airway. So Dr. Gustav Killian did the first bronchoscopy in a patient with tracheostomy in 1896, and then that led to a lot of other advancements and other procedures, like he did fluoroscopy, he used fluoroscopy, he used, at least tried putting stents in, he pulled out the first foreign body, and then he also used radiotherapy. So he's really considered the father of bronchoscopy. He trained Dr. Jackson, and he's the Dr. Jackson who came up with the Jackson trach. So Dr. Jackson learned from him and then brought bronchoscopy to North America. And a lot of things that today we take for granted, like having a dedicated staff, having some kind of pre-procedure, intra-procedure, post-procedure follow-up, having a like suction in the bronchoscopy light, all those things that we now take for granted were actually thought of and written by Dr. Jackson. He was very nice academician. So this is Dr. Jackson, who's considered the father of American bronchoesophageology. And then Dr. Kubo, he also learned from Dr. Killian and brought bronchoscopy to Japan, and Japan is important in bronchoscopy because the first flexible bronchoscopy was invented in Japan. So what Dr. Jackson did in North America is more or less what Dr. Kubo did in Japan, and the bronchoscopies were done in the Killian chair, and I'll show you a picture of it. The Killian chair was basically a chair that had a little bit of a depressed bottom, so the patient had to sit with his neck up, and you had to put the scope straight down. But he sort of modified that as well. So this little fun fact. I don't have the clickers. I always forget that part. But a little historical fun fact. Who discovered the anesthetic effect of cocaine? Why is cocaine important? It's very important, right? From both the doctor's and patient standpoint. But see, when bronchoscopy was being designed, the three biggest challenges to bronchoscopy was anesthesia, light, and instrument. And the history of bronchoscopy is so interesting because it's all started in Europe. They had to wait an entire year where the light was just enough and just right for like 15 minutes in a day, and they would be able to look at something for like 15 minutes, like the vocal cords. There was an opera singer who actually looked at his vocal cords while singing. That was like the first live ENT procedure. So cocaine was important as an anesthetic. But who's the first one who designed or discovered the effects? Dr. Gustav Killian, Dr. Osler, Sigmund Freud, Dr. Tinsley, or the cashier at my local 7-Eleven. Sigmund Freud, yes. Sigmund Freud was a nobody, and he was trying to get some money to get married, actually. And during that process, he was actually using cocaine to detox morphine addicts. And during the process, he found out that actually cocaine is a good anesthetic, but he didn't take it seriously. He said, well, who cares? So he told it to one of his friends who was an ophthalmologist, and ophthalmologist needed a good topical anesthetic. So that ophthalmologist presented that work in one of the international societies and became famous for bringing cocaine as an anesthetic. And Sigmund Freud lost his chance, but he became famous for other reasons. So Dr. Sigmund. Okay, these two are important people in the history of bronchoscopy. This is Dr. Ikeda, who's the inventor of flexible bronchoscopy, 1968 in Japan, and that's Dr. Dumont, the guy who the Dumont stand from France. So he started flexible bronchoscopy. He started interventional pulmonology in the contemporary sense of the word. Okay, this is the first flexible bronchoscope by Dr. Ikeda, so it had a little eyepiece. And this is sort of the timeline that tells you the history of bronchoscopy. So for many, many, many years, actually some decades, rigid bronchoscopy was the only thing that was done. And there were not that many people who were doing it. And then in 1966, 68, maybe are done today actually started because flexible bronchoscopy came on the field. Now, EBUS and navigation bronchoscopy came around like 2000, 2001. Since then, things have been slow, and a lot of work is being done in sort of fine-tweaking this advanced bronchoscopy. So this timeline over here is, a little bit empty. But this just gives how one advancement area can just spawn an entire field of inventions. This is how bronchoscopy was done. This is the Killian Chair. I don't know if you can see it. This is Dr. Gustav Killian. This is, I think, a medical student or somebody just passing by. And then this is the patient / volunteer. And this is, I guess they call him conscious sedation. So that's how it was done. I mean, a little bit of cocaine, and then that's it, right? Nothing else. But this is where bronchoscopy has come. So now you have a bronchoscopy suite with obviously all kinds of advanced equipment. You have electrocautery, cryotherapy, balloons, super D or navigation. You have EBUS, you have autofluorescence, you have stents and APC, and a lot more. So bronchoscopy, the history of bronchoscopy is actually very, very interesting, not just from the technological standpoint, but also historical standpoint. And I like this. Dr. Becker from Germany wrote a very nice book chapter on the history of endoscopy and bronchoscopy, and there's some interesting quotes from how bronchoscopy was first perceived. When the idea of bronchoscopy was presented at the New York Academy of Medical Sciences by Dr. Horace Green in 1846, this is what the reviewers said. Monstrous assumption, ludicrously absurd, and physically impossible. An anatomic impossibility and unwarrantable innovation in practical medicine. See, reviewers used to be so subtle in those days. Now it's just like... And then Dr. Kirstein, who was actually a gastroenterologist, he was trying to do an EGD and accidentally ended up in the trachea. And so he was the first one to accidentally see live trachea. And I like the word. He's just almost like, he's in awe because he saw the trachea in a live patient. He said, I convinced myself that one can pass the vocal cords intentionally with a middle-sized esophagoscope into the coconized trachea, right down to the bifurcation. But the region of the lower trachea is a very dangerous place. The rhythmic protrusions of its wall is a regular and awe-inspiring phenomenon. So sometimes I remember these because it tells you, how far we have come. We just go through the vocal cord and boom, 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 right, left, But for someone who did it for the first time, it was just like, Neil Armstrong landing on moon. And this is from, I think, 2001, because now we're going into the era of robotic bronchoscopy. And somebody wrote a comment, and I don't know if this is serious or not, but it looked pretty serious to me, because it's in this book. He said, these robots might undergo an evolution from mere machine to transcendent mind, and therefore run out of control. And he said, I advise to refrain completely from their development, or at least perform such experiments in outer space, far from our planet. Anyway, so that's just a little history. So it's important to know these structures. Most of the time when we go in and we look at the vocal cord, we just look at the vocal cords, put some lidocaine. Sometimes there can be pathology right and left. And you have the false vocal cords, or the the vestibular folds, and then you have the true vocal cords. So looking at the vocal cords, how they're moving, are they atrophic or not. Sometimes you'll see glottic webs, which are basically thin strands between the vocal cords. Those can be important. But most of the time we don't pay a lot of attention here, because most of the pathology that you find here cannot really be treated by us. We can't really biopsy them. And I generally advise, even say you have a mass or a polyp here, do not biopsy it. Because if you end up bleeding in the upper airway and you have nowhere to control it, you can end up in a lot of trouble. So if you find some major pathology, take some pictures, give good description, and then move on. All right. Little bit about the tracheobronchial tree. And this is important for patients to know, or for us to describe to the patient, and I'll tell you why. So the tracheobronchial tree is a 23 generation airway. Right? The trachea is generation 0, then right left bronchi, which is first generation, then lobar bronchi second, and segmental bronchi third generation. 3 main landmarks in the bronchi, as you know. One is the carina, the most prominent landmark. One is the right minor carina, also called RC1, and then the left minor carina, also called LC1. Why is it important? Because say you have a patient coming in with hemoptysis and has an unremarkable chest CT, and you say, we're going to do bronchoscopy on you, right? So this tracheobronchial tree is pretty extensive, 23 generations. And with the normal scope, you can only examine up to a third of it. Right? So you have ultra-thin bronchoscopes that can take you a lot farther, but the optics and the suction starts to suffer, so you can't really see much. So it's important for us to describe to the patient that we're going to look in your major airways, but if we don't find anything, it does not mean there's nothing there, because there could be something in the 8th, 9th, 10th, 12th generation bronchus that we did not see. The good thing is that if you can see the central airways, which are the airways that you are able to look at with the scope, and you don't see anything major, the chances that you actually missed a significant pathology are pretty low. But still, it's important for patients to know that there could be something pretty distal. I'm going to skip this. Now, this is just to let you know that there's this Japanese classification of the tracheobronchial tree. They go by B1, B2. I have not found any reason so far to know this. There was a time when I knew this, and then I honestly forgot it because I never had to use this. So I honestly don't think that you really need to worry about it. I cannot remember any physician calling me or any surgeon telling me, hey, there's a problem in the B1A. It's always right upper lobe, right lower lobe, right middle lobe. So I would want you to just forget it. Just know that it's there. Sometimes when we put valves in, that becomes a little bit more important. This is mainly for people who do therapeutic interventions. But just to let you know that the trachea is about 10 to 12 centimeters long. In an average male, the trachea diameter is close to 20. In an average female, close to 15. And it's important because if you see tracheal stenosis, you need to have an idea of how bad it is. Usually patients start having symptoms when the tracheal diameter is less than 50% of normal. So if you see something that's really tight, you need to have an idea what the normal diameter was. We know that the right main stem bronchus is much shorter and is more in line with the with the trachea. That's why aspirated food generally goes to the right side. The left main stem bronchus is much longer, and then the other segmental airways are much smaller. So this is what I was referring to. This is your regular bronchoscope. I think most of the Olympus scopes in diameter are close to about 5.8 to 6 millimeter. So they can only take you up to maybe the 4th and 5th generation scope, and then with your camera you can see another 1 to 3 generations. So you can really see about a third of the tracheobronchial tree. With the ultra thin scope, you can go much farther, but then your optics start to get smaller, your suction channel starts to get smaller, so vision does suffer. This is also important, not because it's of any major, like pathologic significance, but sometimes you see a lot of anatomic variations, and you almost wonder if this is some kind of an abnormality. These are some studies. Most of them were done in the Mediterranean population, like Greece, Turkey, and they found that there are 20 different anatomic variations of the tracheobronchial tree. And based on the population, some of them will have, up to 43% of the population will have some variant of the tracheobronchial tree. The most common site, I think most of you who have done bronchoscopy, you'll see that the right upper lobe is, anytime you go in, most of the time it's, two segments are fused together. They're, maybe an extra segment. We have a patient who actually has almost like a separate right upper lobe. They're basically two right upper lobes. Left upper lobe is another common site of anatomic variation. Right midlobe and lingula almost never have any. What is the significance of it? Pulmonary resection is one. So if somebody is doing a sleeve resection for lung cancer and say the right mainstem bronchus is very short, it can be difficult. Lung transplant is also important. Then people who do therapeutic interventions, like you're putting a brachytherapy catheter for lung cancer, if the segment is very short, very distorted, it can come into play. But generally, it's just an interesting finding. I would just want you to know that you'll encounter it every now and then. About some of the findings that you see in the central airways during bronchoscopy. What is this? Saber sheath trachea. A very common finding of little to no clinical significance, but I cannot tell you how many patients get referred to me for this, because somebody out there did a bronch because there was a COPD patient with some kind of respiratory problem. They did a bronch and they saw this, and they referred the patient for stent placement because there's tracheal stenosis. This is basically patients who are old, who are very frail, who have been smoking, who have been on steroids. Their lateral wall of the cartilage becomes weak, so every time they breathe out or cough, the lateral walls come in, and it looks like a anteroposterior slit. That's called a saber sheath trachea or a saber trachea, really of no clinical significance. This is another one of those things that you'll see quite commonly. It was a finding that was generally ignored, but now there's a lot of literature on it. Excessive dynamic airway collapse, where the posterior wall of the trachea bulges in with coughing and forced expiration. And again, this is a situation where they'll send patients for stent placement. Most of the time, this is because of small airways disease or obesity. So you don't generally treat it unless you've ruled out all other causes. This is a little difficult to see, but this is, you can think of it as an advanced form of EDAC. This is tracheobronchial, where you have weakening of the tracheal cartilage along with weakening of the posterior wall. So there's concentric constriction of the trachea. So these are common observations and are now more commonly described. You will see these two in COPD patients or patients with small airways disease like asthma, and you will see this in patients who have primary cartilage problems. So this is a little picture that describes different kinds of what's called central airway collapse, which includes EDAC and tracheobronchial together. So this is normal trachea, posterior membranous wall with the C-shaped cartilage. EDAC, or dynamic airway collapse, which is normal, is when the posterior membrane bulges in. If it bulges in more than usual, and what is more than usual is again debated. Some people say more than 50%, some people say up to 90%. But clearly, if it's very obvious, you'll see it. That's called EDAC. And then you have different types of tracheobronchial. We talked about the saber sheath trachea, where the lateral walls are weak. Then this is the anterior, where it's just the anterior wall, and then concentric. If something like this is found during bronchoscopy, the question arises: are the patients dyspneic because of this, or is this just a finding from the small airways disease? And that's all a difficult question to answer. Sometimes you have to put a stent in and relieve these kinds of central airway obstruction. If patients feel better, it means that the obstruction was partly because of it. A little about sedation and anesthesia. And honestly, it is not my favorite topic, but studies keep coming out on this. Nobody lets go of this subject. So I feel obligated to at least touch on it. What do you use for sedation? A lot of people have used all kinds of medicines. The most common, and if you look at the ACCP guidelines, they'll say some kind of benzodiazepine and some kind of narcotic. Most of the time it's fentanyl and midazolam, which is what we use here. There are studies with etomidate, there are studies with ketamine, there are studies with propofol. I don't think anybody uses cocaine, but we generally use lidocaine. And there are other medicines that have been tried. Most of them are expensive, difficult to administer. But does it even matter which sedation you use? You would think that if patients were better sedated, we would be able to do better bronchoscopy. That's what we think. Having said that, none of the studies that have been done have actually shown it. These studies have not been done in basic bronchoscopy. Most of these were done in advanced bronchoscopy like EBUS and navigation, because over there you generally tend to spend more time than basic bronchoscopy. So there was a study in 2009 where moderate sedation was tried against deep sedation. This was retrospective, and again, there was no difference in EBUS. There was another study in 2010, again looking at EBUS. There was good patient satisfaction. There was this one study, this is from Johns Hopkins, 2013, where there was a little higher yield, 80% versus 66%, and more lymph nodes could be sampled with deep sedation versus moderate sedation. There was a lot of criticism on this study, and even Lonnie Yarmus, who did the study, wasn't very satisfied with the results. Roberto Casal from UT Houston, this is the only prospective study in bronchoscopy that has looked at sedation. So they randomized patients to EBUS, and patients either got moderate sedation with fentanyl versus general anesthesia. And they found that there was no difference in either diagnostic yield or major complications or patient tolerance. I think the only important point about this is that there were no trainees involved in this study. And I think Bilal is actually looking at our data at the VA because we do general anesthesia or moderate sedation. And I think if we get some data, that will be the first time this will be looked at in a training setup, right? There was another study in 2016 which again looked at EBUS, moderate sedation versus deep sedation. There was no difference. So I think honestly, when it comes to sedation, general anesthesia is better because it allows more time for the trainees to learn bronchoscopy. Having said that, from the patient's perspective, it doesn't make a difference. All right, so I briefly discussed the diagnostic, therapeutic, and functional part of bronchoscopy. So these are important terms. You want to know if you're doing mainly diagnostic bronchoscopy, diagnostic plus therapeutic, or just therapeutic, and then we'll talk about functional bronchoscopy. What's the simplest therapeutic bronchoscopy that you can do? Yeah, suck out a mucus plug. We don't think of it as therapeutic bronchoscopy because most of the time it's so effortless. It's just like routine. You go, you see some goo, you suck it out, done, right? But that is really therapeutic bronchoscopy, right? But then you can expand that concept to a lot of things that are done in the IP world. Okay, I put these pictures because this is important. What is this, fellows? Biopsy forceps. What is this? Or a needle, right? What is this? A brush. The reason I'm bringing this up is because I cannot tell you how many times when I go in G-Gastro and I'm editing the note that the fellow has put in, if he did an FNA, they say, FNA biopsy was done, or brush biopsy was done, right? And then I get a call from billing, and they say, did you do an FNA or a biopsy, right? So biopsy is a separate procedure. This is not a biopsy. This is an FNA, not a biopsy. Brush. Dr. Saad will tell you 31628, 31625, 31629, and 31623. Okay? So please, if you see Amy take something out like this, not a biopsy. Brush. If you do something like this, not a biopsy. Needle, FNA, TBNA. If you do something like this, if you're using fluoroscopy, it's transbronchial. If you're biting something that you can see, it's endobronchial. All right? Okay, So let's go through some of these basic diagnostic techniques. This is really what's important for this lecture, right? The diagnostic part of bronchoscopy. So we know for central endobronchial lesion, you can do a lot of different things. You can do an FNA, bronch wash, brush, forceps. For peripheral lesions, you can again use biopsy, forceps, brush, curette, which nobody really uses. I think the Japanese somehow are fond of it. BALs, and then you can do TBNA, and then the hilar lymph nodes or mediastinal structures, you can use either the cytology needle, which is usually 21, 22 gauge, or the histology needle, which is usually 19 gauge. So I'm not going to go through all of this, but some of the important points are highlighted. For central endobronchial lesion, what is an endobronchial lesion? Something you can see, right? If it's in the central airways, if you can see it on your scope, that's an endobronchial lesion. And generally, you can either biopsy it with forceps, and there are all kinds of forceps. Usually at the VA, Susie will ask you, do you want alligator or alligator with a spike or cupped, and depending on my mood, I will say whatever, right? Why? Because there's no study that has shown that one is better than the other, right, as far as diagnostic yield is concerned. If it's something that you think you really need to bite hard, then choose something with a spike or with an alligator jaw. Larger forceps can give you larger tissue, but that doesn't translate into better yield. And also with things like small cells, sometimes larger forceps will give you a bigger crush artifact, which at the VA is a big deal because you can send them 36 pieces and they'll still tell you not enough tissue. Okay, so if you think it's small cell, just be a little gentle. Okay, do not crush tissue. Sensitivity for biopsy in central lesions is pretty good, 90%. You want to take at least 4 biopsies. The data will tell you there's no increase afterwards. The problem is most of this data comes from the pre-molecular studies. They weren't looking at immunohistochemical stains. They weren't doing their EGFR. They weren't doing foundation 1. So if it's easy to bite, it doesn't bleed, just get as many pieces as you want. Then remember that if you're doing biopsies of renal cell carcinoma in the lungs or Kaposi's or carcinoid, you want to be a little careful because they can bleed. A lot of people do brushing for central endobronchial lesions, and data will tell you that you can get up to 72% on the yield. What's the problem with brush? Brush is just like you're rubbing on the lesion, and a lot of endobronchial lesions have a thick coat of necrotic tissue. So if you just go in and brush right away, all you're getting is the superficial necrotic tissue. So just be careful. The best thing to do is to do a brush after you actually dug into the lesion and expose the underlying tissue, if you're going to do a brush. Bronch wash is really next to worthless when it comes to endobronchial lesions. I generally get washes after I've done everything and there's a lot of blood and secretions and potentially cancer cells in the airway, because again it's about getting more tissue, and bronch wash is generally a very easy and harmless thing to do. So if you want to get a bronch wash, just put like 30, 40, 50, whatever cc's of water on it after you have done everything, and then you can send it. TBNA, that's the needle part, right? What's the good thing about TBNA in endobronchial lesions? They can pierce the lesion, right? So you can get to the core of an endobronchial tumor and get tissue from underneath. That's why the yield is pretty good, about 91%, plus potentially it is less traumatic to lesions. So if you have renal cell carcinoma or Kaposi's or carcinoid that you think is going to bleed, it's good to do a needle aspirate first. So say you do a bronchoscopy on a patient. This is actually one of the patients who referred to us for central airway obstruction. So you do a bronchoscopy, you put a scope in, you're looking down the trachea, you've got this huge big mass just blocking the left main stem, you can see a little bit of the right main stem. What do you think? This is, again, it's not hard and fast, but generally this is what I want you to remember. What is the most appropriate sequence of tissue sampling for the mass seen in this picture? You'll do a brush first, then endobronchial biopsy, then FNA, or FNA with endobronchial biopsy, then brush, or endobronchial biopsy, FNA, brush, wash, brush, transbronchial biopsy. Dr. Price. So it's two. It's two. I told you, with a brush, if you rub the brush on it, what are you going to get? Just mucus and junk, right? And at the VA, we already struggle with large tumors to get a diagnosis. You don't want to send them mucus and junk and tell them there was a tumor. So the best thing will be you go and you don't know if this thing is going to bleed. It could, or it may not, right? So the best thing is you stick a needle in there with an FNA, get the core of it, put it on a slide, give it to your cytopathologist, which is right there. He gives you a diagnosis. You can maybe do another one or two, and then you can biopsy it. So with endobronchial lesions, the first thing that you want to do, if you're really suspecting malignancy, which most of the time we are with endobronchial lesions, you want to go with an FNA first. Okay? It's less traumatic, gets you the core, you can put it on a slide, get a rapid on-site cytology, you can even check if it's going to bleed or not, and then go with the biopsy. And like I said, the brush, if you're going to do it for endobronchial lesions, just make sure there's a lot of blood and secretions in the airway, because potentially there will be cancer cells then. But brush is really less important. But always remember, FNA before endobronchial biopsy. And this is generally, just emphasizing the fact. For benign lesions, endobronchial lesions generally are approached as malignant, where very rarely you will, find that they're benign. Benign tumors of the airway are very uncommon. So with benign lesion, you can really follow any sequence. We generally just go straight for forceps. But if it's a malignant lesion, if it's a tumor, stick a needle in first, then forceps. Okay. What about peripheral lesions, like out in the periphery? You can either use EBUS, like radial EBUS, or navigation, or fluoroscopy. So with peripheral lesions, as you have noticed, there's a lot of difficulty getting to the lesion. And if you have gotten to the lesion, getting a biopsy. Why is that? Because obviously you're dealing with a 23-generation tracheobronchial tree, and fluoroscopy is a 2D image. So it cannot tell you if you're in front of the lesion, behind the lesion, or in the lesion. It can tell you that you're in terms of superior, inferior, and median, lateral. It can tell you where you are, but it cannot tell you if you're in front of it or behind it unless you rotate the fluoroscope. So size of peripheral pulmonary lesions and the distance from the hilum is something that really determines if you're going to be able to biopsy. Just remember, if it's a 2 centimeter or smaller lesion in the outer third of the lung on fluoroscopy, the chances of getting a biopsy with fluoroscopy alone is about 20% or less. And this is based on studies, I think published in 2001 in Chess. Very nice study. Now with navigation and guided bronchoscopy, we have been able to increase this number to about 70-75%. All the guided bronchoscopy in a very well done meta-analysis, whether you use radial EBUS with navigation, navigation alone, radial EBUS with distance, what they call a radial EBUS with guide sheaths, or any combination of those, generally gets you to about 70%. So that's the number that you should remember. When I talk to patients about these peripheral lesions, I say we have about a 70-75% chance of getting the diagnosis. So that means about a third of the times we may not get the diagnosis. So talking about non-diagnostic bronch is very important, because no test gives you 100% result. TBNA for peripheral lesion, again, if you can get to it, has a very good yield, and most people will say go with the TBNA first. Why is that, Dr. Jalil? Why do you think a TBNA, at least in theory, will give you a better diagnostic yield than a forceps biopsy for a peripheral pulmonary lesion? So this is what we have found. Remember that timeline where we were going, we were going on this path of innovation, and at like 2000 it just sort of stopped. Well, what happened? So in 1999 radial EBUS came out, 2000 linear EBUS came out, 2001 navigation bronchoscopy came out. Wonderful news, great, because all of them were designed to take us to the lesion, right? And all of the people who are working in this area were thinking, if we can get to the lesion, we will get the diagnosis. Well, what they realized by late 2000, after all these studies had come out, is that getting to the lesion was half of the problem. Because what really determines whether you will be able to get a diagnosis at that point when you're there close to the lesion is the relationship of the lesion with the airway. So if the lesion is in series, like right, the airway is going right into it, then your diagnostic yield is higher. You can put the forceps, it's going to follow that guide sheath and go right at the lesion. But if the lesion is parallel to the airway, well, with your radial EBUS, you're going to be seeing through the airway and you'll feel like you're there. But when you put the forceps, your forceps is in the airway while your lesion is right next to it. So that's the biggest explanation, perhaps, for the 70% yield, along with the fact that you have respiratory motion. So what the needle can give you potentially is a way to traverse the airway at that point. So it can go through the airway and get you to the lesion, whereas a forceps cannot. So most of the innovation that has been done in guided bronchoscopy since that time is basically working in that part, trying to come up with instruments that can somehow take you to the lesion, or you can tell you if with respiration the lesion is moving or not. BAL for peripheral pulmonary lesions is, if you're looking at malignancy, is practically worthless unless you have lymphangitic carcinomatosis or one of those minimally invasive adenocarcinomas. So if you have what looks like minimally invasive adenocarcinoma or lymphangitic carcinomatosis and patients are pretty sick, they cannot tolerate a biopsy, just go ahead and do a BAL. And you'll be surprised how many times it will actually come back positive. So in that case, the BAL can be helpful. There's something called a bronchus sign, where on a CT you can see an airway going to a lesion. With navigation bronchoscopy, there's one study at least that showed that if you can see something like this, it increases the yield of your biopsy. With radial EBUS, there is no such study, but intuitively you would think that if there's an airway going to the lesion, that's pretty good. So if you can see something like this, and again, this is a situation where you want to decide if bronchoscopy is the right route to get to it, or is it a transthoracic biopsy. So if you see something like this, and patient is a decent candidate for bronchoscopy, then you have a good chance of getting to the lesion, because transthoracic biopsy, although it's relatively simple, straightforward, does carry a much higher risk for pneumothorax, about 15% as opposed to about 5-6% for bronchoscopy. Again, with peripheral pulmonary lesions, if you're suspecting cancer, go with a TBNA first if you can. This is based on some weak data. So whether the lesion is endobronchial or peripheral and you're suspecting cancer, try to go with the needle first and then the forceps. This is something that I think I'm going to skip. You generally learn it. This is the mediastinal lymph node staging. You generally learn it when you're doing EBUS. So the purpose of this talk is not to make you a good bronchoscopist, but a smart bronchoscopist. So this bronchoscopy is not something you're going to learn on this table. But a few things about the hilar mediastinal lymph node. They used to call this blind TBNA or conventional TBNA, which is now rarely done. So I feel like this slide has become somewhat redundant. It's just of historical importance. The diagnostic yield, as you can see, is 15% to 80%. It's like all over the place. And the reason is that a lot of it depends on the skill of the operator. A lot of it depends on how big the lymph nodes are. This is where EBUS has really made a huge difference, basically kicked this thing out of the practical medicine. If you're going to do a lymph node aspirate, the main question is how many times should you aspirate a lesion? Based on many studies, up to 4 passes maximizes the yield. Beyond that, there's very little increase in your yield. So try to do about 3 to 4 passes if you can. With EBUS, it's a really different picture, but if for whatever reason you end up doing a conventional or blind TBNA, try to get at least 4 passes. And then when you're doing a sampling of the lymph node, what is most important is to, number one, sample the lymph node before you sample the cancer, and always go for the lesion that is going to give you the highest stage if it were positive. So say that tumor that we found, if you go straight for it, now you spill cancer cells in the airways. And now if you go and biopsy a lymph node and comes back positive, the bigger question will be, well, is it positive because the airways were contaminated, or is it positive because the lymph node is positive? So always try to go for the lymph nodes before you sample the tumor. I guess this is my least favorite procedure to do in bronchoscopy, the BAL. And I'll tell you the reason. Because I feel like you have no control as a bronchoscopist on how much you're going to get out. With everything else, there are things you can do, you can try, you can tweak things up and down and try to get a better yield. With BAL, it's like you're the victim of circumstances, right? You pour it in and you suck out, and then you realize how bad you suck. But there is one study, this is important. So they've done this digital subtraction radiography to see how much water you actually need to really get the alveolar part of it. And this was interesting for me because you need about 120 cc's to really get to the alveoli. Otherwise, if you put about 60 cc's, which is generally what we do, because at the VA our patients are old and frail, BL is really controlled drowning. That's what it is. So how much drowning can a patient take depends on who the patient is, right? You've got a 25-year-old, otherwise healthy patient. You can pour like 200, 300 cc's in his lung and he'll do fine. But you have one of those 87-year-old on 2 liters oxygen, bad lungs. I mean, he may just not do well after 40 cc's. So really you have to judge yourself. But you do have to remember that you do need to pour close to 100 cc's if you're really going to get the alveolar part of it. And then we've seen this, all the fellows know it. All those collapsible airways where you suck it a little bit and it just closes down on you. There is no way you can get a good BL on it. If you are doing a BL for a diffuse lung disease, try to put the right mid-lobe and the lingula, just because the orientation of those segments is such that you actually pour it in and you suck it out so you get a better return. Otherwise, if it's a focal lesion, you'll have to go in that segment. This is something that I always tell patients, because you will be surprised how many times patients will call you back and say, I have a little fever. So BAL can actually cause a low-grade inflammatory reaction in the lungs, and it's very common for patients to have low-grade fever. So when you're getting consent for patients, always tell them that low-grade fever after bronchoscopy does not mean that you have a pneumonia. And they can take Tylenol for usually about 24, 48 hours. It's gone. Yield in bronchoscopy in BAL for bacterial pneumonias can be up to 75%, TB up to 70%, but lower in miliary TB. One study looked at BL yield in bacterial pneumonias on patients who were already on antibiotics, and they found about 40%, which was a little bit of a surprise for me. And then fungal infections anywhere from 15 to 80%, depending on many factors, including the fungus. Some fungus is easy to grow, others are not. So I generally remember about 50%. I tell the patients there's about 50% chance of finding the organism. And if you look at pneumonia data, generally about 50% of the pneumonias are culture negative. What is the normal composition of BL? We know it's mostly macrophages, and it's larger in smokers. Some may have inclusion bodies, and then the CD4-CD8 ratio is important. Which disease causes a reversal of CD4-CD8 ratio? Arjun? Sarcoid. So sarcoidosis, CD4-CD8 ratio, the CD4 cells will be much higher. CD8 will be low. In HP, it's the reverse. That's why it helps, because both of them can be granulomatous. Both of them can have lymphocytes in the BL. And at the hospital, I worked with the Hempath lab, and they have a special order for us now. So if you're suspecting ILD of any sort, and you want to actually just specifically check CD4-CD8 ratio, the nurses down there know to put the flow cytometry order on the BL, 2 to 8, and they'll send it, and you get the results within 24 hours. So it helps. Again, this is not something I'm going to go into, but just remember that sarcoidosis and hypersensitive pneumonitis both have high lymphocytes in the BL. Which one of these diseases has the highest lymphocyte count? Sarcoid is actually second. It's actually HP. HP has a very high lymphocyte count. Is that right? It's right? Yes, HP has the highest lymphocyte count. Sarcoidosis is a close second. Okay, so you're asked to perform bronchoscopy in a neutropenic patient with diffuse pulmonary infiltrates. Dr. C says, I want it done today, right? He's suspected of having pneumonia. Which of the following modalities provides the highest yield in this patient? BL alone, BL plus transbronchial, BL plus transbronchial plus brush, TBBX alone, TBBX plus brush. This is important too, because far too often we miss it. Dr. Delap. 2, very good. So this is based on this study published in Chest 2004, non-HIV immunocompromised patient with pulmonary infiltrates. So they looked at all these combinations and they were trying to find out which one of these combinations gives you the highest diagnostic yield. Now this is patients with suspected infection, and so they found out that BL plus transbronchial biopsy gave you about a 70% yield. What was important to know is that adding a brush really didn't make any difference. So doing brush, out in the lung when you're suspecting pneumonia is really not needed. So if you're suspecting infection in an immunocompromised patient and you can do a biopsy, patients can tolerate it, you don't have to tank them up with several units of platelets, then go ahead and do it. Said that, it also depends on your pretest probability. So you have a bone marrow transplant patient who has some chronic interstitial opacities and there's really no evidence of infection. You don't have to do a biopsy because biopsy does come with a certain risk of pneumothorax. Yeah, for CMV you need it because CMV can be in the BAL, but unless you see the cytopathic effect, you can't really make a diagnosis. Aspergillus is another one because aspergillus can colonize the airways, but unless you see it invading into the tissue, you can't really technically call it a invasive aspergillosis. Now this is another one of those issues where patients are intubated in the ICU, they need a biopsy, and people don't want to do a biopsy because it will drop their lung. It's not supported by evidence. This study in 1997, that's a long time ago. We didn't even have iPhones back then. So retrospective study of these patients who were intubated and they did biopsies. Bleeding of more than 30 milliliters was only found in 6%. Pneumothorax risk was about 15%, which probably is a little higher than non-intubated patients, which is generally 10%, but it is still acceptable. I mean, 15% is where transthoracic or CT guided biopsy is. So if there is if patients are not on enormous amounts of PEEP, like 15 or 20, I think you can do biopsies if it's clinically indicated. The thing is that most of the time when patients are intubated in the ICU on the ventilator with respiratory failure, the chances that a biopsy will change management is minuscule. So that's a better reason not to do a biopsy than to say, I'm going to drop their lung. If there's a reason you want to do a biopsy and you think the biopsy can change management, go ahead and do it. Pulmonary hypertension. Dr. L. Kirsch, who just walked out, he actually brought up a good point the other day that this is an area where research can be done, and any one of the fellows who's looking for a research project, there is this only one study that has looked at risk of bleeding with transbronchial biopsy in patients with PH. I think this was from Cleveland Clinic, and these were patients, they looked retrospectively, 45 patients of PH, 45 control. They have significant PH and were on oxygen. There was no difference in bleeding risk. But this is a retrospective study. So the VA has an enormous data, and you can actually tap into the national VA database and look at all those patients, say, who have echocardiograms and had PH and then ended up having. That's that. This is now common knowledge, but when it came out, it made big news. Should we stop Plavix before biopsy or not? So they looked at Plavix alone, aspirin plus Plavix. And the bottom line is that if patients are on Plavix and you are doing a transbronchial biopsy, you have to stop it. Aspirin by itself is not a problem. So stop it about 5 to 7 days before. just a few words about this will happen probably every now and then. Patients come with hemoptysis. They have a chest X-ray that looks normal. They get a CT scan in the ER that looks normal. And the question is, if you do a bronchoscopy, which most likely you will, what are the chances that you'll find something scary with a normal X-ray and a normal CT scan? There are several studies that have looked at it, but these are the more important ones. So with a normal chest X-ray, 20% you'll find something, right? And then lung cancer in this study with the normal chest CT was less than 3%. Okay, but you still do it because we have lawyers. Therapeutic bronchoscopy, I'm going to skip. I think most people know. So let me just introduce this term. Again, it's sort of out there. People are working on it. It's not really mainstream. What is functional bronchoscopy? It's a bronchoscopic way to test function of the airways. Right, so we see endobronchial obstruction like tracheal stenosis, or we see central airway collapse. Do we know if it's actually functionally or physiologically important or not? So functional bronchoscopy, this is a way to basically see if patients can be improved by improving that airway obstruction. So you do bronchoscopy on patients who are actively on CPAP. And then you raise the pressure until the airways start to open. And then you say, okay, at 15 centimeters of water, your central airways are open. And then you can send home on 15 centimeters of water, CPAP, even for a few hours. If they use it, say just at night, sometimes they feel better. If they feel better, sometimes there's an indication that actually this central airway obstruction may be causative and not just a finding. We are actually able to do it down here, and I think even at the VA we haven't tried it, but we have the ability to do it.
So you put the patient to sleep?
Yeah, I mean, they're just lightly sedated. With these kinds of bronchoscopies, we generally like to keep patients a little awake because we want them to cough, we want them to turn their head because the airway dynamics can change. So we keep them a little lightly sedated. We put a CPAP mask on, and we have a special CPAP mask for it. We can put the scope through, and then first we do bronchoscopy without CPAP. If they're already on CPAP or sleep apnea and they use a pressure for like 12 centimeters, we put them on 12 and see what their airways look like. And sometimes with central airway collapse, as you increase the pressure, you can actually see their airways open up, and then you say, this is where your airways or stay open. Because one of the problems with central airway collapse is not just shortness of breath, it's retained secretions, wheezing, and cough. And that can definitely get better. This is another form of functional bronchoscopy called morphometric bronchoscopy. In one of the meetings, IP meetings, they showed a lot of these pictures of central airway obstruction from tracheal stenosis, and they asked the crowd, how much obstruction do you think there is? Somebody said 30%, 50%, 100%, like all kinds of numbers. Because it was all subjective. So this is a way you can actually find this program on the NIH website. You can download it. You can take the bronchoscopic pictures and put it in there, and it will give you actually a way to objectively measure what's called the stenosis index, and you can actually track it. So say you do intervention, you improve the stenosis index from 30% to 50%. That's an objective measure that you can follow. It takes a little bit of an effort, but again, it's better than just subjective assessment. This is another form of functional bronchoscopy called YBN Response imaging. Studies were done like early, 2000 or so in Germany mainly. So when you take a deep breath in, air goes through your airways into your lungs, then sort of vibrates your chest wall, and you can feel those vibrations, right? So all these are sensors on a vest, and they turn the vibrations into a picture. So that's the normal picture. So your airways and your lungs are nice and open. As you can see, there's uniform distribution. But say if there's an airway obstruction, this is left main stem bronchus, or airway obstruction. Now you can see the obstruction, but how do you know how bad it is? So you do a vibration response imaging before. So there's less airflow here, less vibrations, and then you do your laser or whatever you're going to do, and you improve it. So this is almost like a TEE with Doppler. You see a valve that's obstructed. Now you want to see how bad is this aortic obstruction. So this is a way to objectively check. The only problem is that because of secretions, you can get a lot of vibration. All right. Just maybe 1 minute or 2 minutes on bronchoscopy training. I like this when I think about training and education. They said the belief that all genuine education comes about through experience does not mean that all experiences are genuinely or equally educative, right? They say practice makes perfect. It actually does not. Practice just makes you permanent. So if you're making the same mistake over and over again, you could do it for 30 years. That doesn't mean you're better. You're just now, permanently, I guess, disabled. All right. So when it comes to bronchoscopy training, we know that there are two main kinds of simulators. You have the electronic simulator, high fidelity simulator, which we have here, and we have the low fidelity simulator, which doesn't always look like this, but more or less the plastic model, which we have at the VA, right? So they did this very nice study. This was like a multi-center study by Dr. Ost, where they wanted to see how do fellows perform when you give them these simulators, So they first took these three groups of people, experts, intermediates, and novices, based on how many bronchoscopies they have done. More than 500 was expert, 25 to 500 was like intermediate, and novices were like these guys when they're going to start, right? So then they first gave them the bronch simulator just to kind of see how they do. They, like a dry run, and they took some parameters that they're going to follow. Then they took the new pulmonary fellows, day one, and they randomized them to either conventional method, which was like, okay, here's the patient, go ahead, put the forceps in and bite what you can. That was the conventional method. Versus, okay, you're going to do certain number of bronchoscopies on the simulator before you touch the patient. That's like when the fighter pilots train, huh? So overall, this is not a surprise. Experts did better than intermediates and novices. Okay, no surprises. They found out that after about 20 simulations on the simulator, the fellows started to look like, okay, they were learning something. 20 is actually a lot on a simulator, So I don't know, but 20 simulation, they started to improve in their speed. They could identify the segments well. Time in readout, where you just can't see anything except just the wall, that's readout, and the collisions with the wall. So after they had sort of gone through this early phase, then they looked at these three different parameters, compared the fellows who were trained on bronchoscopy simulator versus the conventional ones to see how they did in their first bronchoscopy. And they had the procedure time, then also the bronch tech basically had a form that he or she was filling out that, yes, this fellow is good, that this fellow sucks, versus there was another bronch quality score. And all these three, they generally performed better, okay? So the moral of the lesson, or the lesson from the story is that bronch simulators work. And this is what I recommend to all fellows who start. You're not going to really learn the skill and procedural aspects of bronchoscopy on the patient. You really are not. You're going to learn it on the simulator, because once you start it on the patient, you have, in conscious sedation, you have about 15 to 20 minutes. Beyond that, patients start coughing and whatnot. So you really need to be, sort of in your stride when you put the scope in the patient. So if you have free time and you're in the early part of your fellowship, go down there and just practice it. That's what I did in my first month of fellowship, which was the sleep month. I actually spent more time in the bronch simulator than the sleep lab, and it actually worked. All right, so we've gone through this. So these are two good websites for bronchoscopy education, Essential Bronchoscopists and EBUS Bronchoscopists. Let's have one slide about the real world bronchoscopy. This is somewhat disappointing. So what's happening in the real world with bronchoscopy? This is a little bit old, but I don't think it's that old. So more than 50% of the practicing pulmonologists felt that there is inadequate training and advanced diagnostic technique, including TBNA. Okay? More than 70% of the bronchoscopists out there practicing perform less than 100 bronchoscopies per year. 70% felt that additional training should be provided to those who are mainly interested, and only 25% of the practicing pulmonologists were actually doing all the procedures that are needed for board certification. So it's strange that a lot of people come to pulmonary because of the procedural aspect, but out in the real world, this is the picture. There was a study published in Chest where they found that less than 15% of the practicing pulmonologists were actually doing conventional TBNA, and less than 25% or so of the fellowship programs were teaching conventional TBNA. This is early 2000s. And this is conventional TBNA. And that study was done because EBUS was starting to come up, and a lot of those people who really didn't care about TBNA, but they started to feel like, oh, let's just make sure this doesn't go away. So that's really what it is. And there are many different validated scores. So anyway, just to kind of emphasize, sedation really doesn't matter, but kind of choose sedation based on what you're going to do. For malignant lesions, whether they're out in the lung or in the airways, go with the needle first if you can, followed by the brush. Do your biopsies in immunocompromised patients with pulmonary infiltrates. If you can, and you're suspecting infection, stop your Plavix 7 days before, and use your free time on the bronch simulator, especially in the early part of fellowship. I think that's it. Questions?